Good morning, everyone. Let's see if you guys can hear me. 20 years of experience. What do you guys think how old I am? Only 8 years of experience. I don't know where are you guys getting those information, but I am delighted to be here, and thank you everyone for coming. We will be discussing some of the pitfalls in the management. So I'll be going over the diagnostic part and then the management part and various myths that are out there. So when we talk about Parkinson's disease, you guys know that it is the fastest growing brain disorder, brain disease in the world. You guys might be thinking, it's stroke or Alzheimer's disease. But when we adjusted it for aging, it's Parkinson's disease. Parkinson's disease has doubled in the last 20 years, and it's projected that it will be doubled in the next 20 years. You guys can see from the graph there. And the question that come across, are we prepared? And the answer is no. And we will be going over that what we need to do. If it is one of the fastest growing brain disease, and we are not prepared now, so 10 years, 20 years later, what would be the situation there? And that's why scientists and experts are calling it pandemic. So pandemic is a word we use for infection usually, like COVID-19 pandemic. But for Parkinson's disease, experts are using this term, and rightly, because it is a pandemic kind of situation. When we talk about Parkinson's disease, there are various stages. So if you look at the left-hand side, we call this a prodromal or non-motor state. And 4 things come into mind. One is anosmia or hyposmia. People lose their sense of smell. Constipation is another thing that come across, sometime even decade before the appearance of motor symptoms. Anxiety, depression, panic attack, that comes before the motor symptom. And also so many other things like sleep disorder, REM behavior disorder. People are acting out their dreams. So that phase, we call it prodromal phase. And then comes when we lose almost 60-70% of those dopaminergic neurons, then the motor phase gets kicked in. And tremor, rigidity meaning stiffness, akinesia meaning slowness, or bradykinesia means slowness, and postural instability. Those things get started, and this mnemonic trap, it's like you guys are trapped then, right?
Yeah.
But then as the disease get advanced, different other things comes, like if you are taking medication, those off and on period, those comes into picture. Then comes those limbic involvement, then comes the cognitive involvement, autonomic involvement, and the story keeps on going. Psychosis, visual hallucination, other types of hallucinations come across. So to just understand this disease, this black area, that arrow in the middle, this what we call substantia nigra, and this is that dopamine-rich area, dopamine-producing area, and when there is cell loss, then people develop those symptoms. And it just works on then those motor circuits, dopamine works on those motor circuits and causes those symptoms like tremor, rigidity, bradykinesia, all those issues. There is a normal protein, all of us, we have that protein, we call it alpha-synuclein protein. And that protein somehow gets phosphorylated and it changes its configuration, and we call it alpha-synuclein protein, and when it clumps together, we call it Lewy body or Levy body. You guys might have heard about those terms. And these kind of things we use sometimes to diagnose Parkinson disease, so you guys might have seen a lot of patients might have done their skin biopsy. One of my patients was asking me if I'm a dermatologist now that I'm doing skin biopsy, but that is not for those reasons, but it is to find out those phosphorylated alpha-synuclein protein. And believe it or not, 95% patient can have those abnormal protein. And then on the other side of the slide, this is called a DAT scan, DAT, also called dopamine transporter scan. So we look at those dopamine producing cells, and if there is loss, so on one side you can see a comma, so it's a normal, and if there is a cell loss, it becomes like a full stop. And there's what we call then positive or negative. But not all of us, we need these scans to diagnose a patient with Parkinson disease, because it's still a clinical diagnosis. So when do we need those scans? So let's say if somebody is on some culprit medications like dopamine antagonist, which work opposite to dopamine or block those receptors or deplete dopamine, then patient can develop features of Parkinsonism, so we can offer those scans. Or if somebody has other issues like functional component or psychogenic issues on top of Parkinsonism, we can separate one from the other. Or sometimes different type of Parkinsonism, especially new studies are coming that the distribution or density of that alpha-synuclein protein would be different in Parkinson disease, Lewy body dementia, multiple system atrophy, or tauopathy is another protein that, of course, this scan would be negative then, right? So there are so many types of Parkinsonism, and this slides, I can go over that. Anyone, including your primary care, I'm not negating their role, can diagnose you with Parkinsonism. Right? Anyone on the way out can tell you that, okay, you have some problem. So there's not a big deal. The big deal is what kind of Parkinsonism, the good, the bad, the ugly. Right? So which one are the good one? If you have tremor predominant Parkinson disease, that is the one that have the good prognostication. People live with this disease forever. 10 year, 20 year, 30 year, 40 year. We call it PD10, 20, 30, 40. If you have postural related disorder, that's the time that we need to talk more. But then there is a huge other list, we call it atypical Parkinsonism. You guys might have heard this term atypical, meaning there are atypical features like memory problem, autonomic dysfunction, bladder issues, blood pressure drop, so multiple system atrophy, progressive supranuclear palsy, corticobasal syndrome, and so many other. Then there is another group, we call it ETPD complex, that if you have essential tremor and when you age, you are not immune to develop another brain disease, and those patients can develop Parkinson disorder. And there's also a good kind of Parkinsonism. And of course, then there are drug-induced Parkinsonism, chemical-induced Parkinsonism, and the list keep on going. I started, and now I have some gray hair, and still I'm scratching my head when I'm with my patient, trust me. So always ask your doctor what kind of Parkinsonism I have. What's the prognostication? What's the things that I need to do? Now, when we talk about Parkinson disease, the things that come into mind is what causes Parkinson disease? Is it genes? Is it environment? Is it aging? Is it something else? So some expert rightly mentioned that genetic loads the gun and environment pulls the trigger. So there is a nice study that is, I think they are still enrolling, a PD generation study in North America. They enroll more than 20,000 patients. And believe it or not, only 12.5% of patient has the genetic form of Parkinson. Genes are causing the problem. But 87% is the environment. Now, a lot of you guys, when you come to our clinic, you are asking for gene testing. And even if we, let's say that 12.5%, when we take the example like GBA and LRRK, those are the most common one. So when we tested those patients and they have the genetic mutation, not everyone then develop Parkinsonism. Like in LRRK 30% and GBA 10%, they progress or they develop Parkinsonism. And what are the tools with us that we can manage it differently? And that's why I think a lot of, any one of you guys have done any genetic testing? Good. And that comes me to discuss this slide, this insecticide and pesticide. And the foster child for this is a paraquat. You guys might have heard about it. Now, any one of you guys know how much paraquat increases the risk of Parkinson's disease? You can shout it.
Well, yeah,
150%. Yeah, and more than 100 countries have banned this chemical, but it's still used, and we are importing it from other countries. Another chemical is DDT, and I think a lot of us been exposed because after World War II, it's been used everywhere. Then comes this another chemical, we call it trichloroethylene. Anyone have heard about that? And you guys might have heard about that, Camp Lejeune. So this is the chemical that is being used in decaffeination, typewriter, and dry cleaning. So in Camp Lejeune, that was the reason that the water got contaminated, and almost 70% of those marine going forward develop Parkinson's disease. Do you guys know what is the risk of Parkinson's disease in patients who've been exposed to trichloroethylene? It increases the risk by 500%. Now, do you guys know how much groundwater is contaminated in US? 30%. Now, I think the rising culprit there is the air pollution. Air pollution, especially those nanoparticles in air that can get trapped and can go to brain, like those nanoplastic that is on the rise, because we are reading and learning more and more about it, that risk of Alzheimer's disease and Parkinson's disease goes high. And if, believe it or not, you go to any third world countries, China included, India, you cannot see a person 6 feet apart from you on the street. And that brings me to this discussion. Is Parkinson's disease a man-made disease? Because when we look at 1817, when James Parkinson described this disease, what was going on at that time? Industrial Revolution. And before that, there were anecdotal cases of Parkinson. Those genetic mutations, especially the LRRK and GBA, are 20,000-year-old mutations. So if it would be just genes, we would have heard a lot about Parkinson from the history, but it's not. So I believe in this, that Parkinson disease, we have done a lot to our environment, our food, and everything else, and water, including water. Now, what exactly are those protective factors that can protect you from Parkinson? So, just to let you guys know, I'm not promoting and telling you guys to start smoking. Smoking is one of the protective factors. And what would be the reasoning behind that? And it's very interesting. There are some hypotheses because smoking impairs the penetration of those alpha-synuclein protein through the nasal and gut mucosa. The second reason for smoking being protective is it affects the reward system. Dopamine is the reward system, right? Or the third thing is people don't live it or make it to develop Parkinson's disease. They die because of COPD and cancers. Now, the second and the one that I really believe in is exercise. And how exercise would help protect you from having Parkinson's disease or progressing of the disease. So you guys might have heard about that Parkinson's disease is kind of a networking deep in the brain, but the control is from the cortex. And when you guys exercise, there are sprouting of new synapses, new connection pathways develops. And that's why it helps short term and long term. And that's why you need to focus on that. And when I say exercise, a lot of time I look at the guidelines and they said 3 times per week. It should be on a daily basis, because if there is a tomorrow in anything, that tomorrow never comes. So it should be on a daily basis that you guys should be doing exercises. The other thing that is interesting is what kind of diet, and you guys ask us also, and you guys can look back and you can decide which diet, which things on the table you will be eating, whether fruits or those other junk food. I'm sorry about that, guys, but it needs to be healthy diet because we are what we eat, right? And that's why there is a huge factor there. And always wash your produce before eating, because those chemicals that's being sprayed is still on those fruits or veggies or all those things. So it's always a good idea to wash it thoroughly. Now, let's discuss this, how Parkinson's disease develop or spread. There is this German neuropathologist in 2003. His name was Hugo Brack, and he postulated this theory that Parkinson's disease develop in the gut. And then it spreads through the vagus nerve to the brain stem that's stuck in the brain. We call it brain stem, and there is a sleep center, and that's why people develop. So when it's in the gut, people develop constipation. When it is in the sleep center, they are acting out their dreams. And the third stage is that black area that I showed you guys, substantia nigra, and when there is deposition of this alpha-synuclein protein, people develop tremor, stiffness, slowness, walking and talking issues. And when it goes to the limbic area and then cognitive areas, of course, those symptoms can come across. But it's still a hypothesis. And that led to this two theories out there. Body first, that I just discussed, that it starts in the gut and then it ascends up. And the nose or brain first, that those chemicals get entry through the nose, because there is a connection pathway through the olfactory system to the brain. So these two hypotheses are out there, body first or brain first. Now, when a medicine is approved or is in the approval phases, there are different stages that it goes through. In the initial one, you guys might have, if you are enrolled in a study, you guys have seen that IPX, ABCD, all those weird names to the medication. And that is before the medication is approved. It's a chemical name. When the medication is approved, FDA or DEA, they give it a name based on the mechanism of action, like levodopa. Levodopa goes to the brain and get converted to dopamine. So on the list, there are those medications based on the mechanism of action, like you guys might have heard about monoamine oxidase inhibitor or COMT inhibitor. It just inhibits the metabolism of levodopa. Then dopamine agonist is a synthetic dopamine that works on those receptors, dopamine receptors. Amantadine has a different mechanism of action, and then we use sometimes not dopaminergic system, but cholinergic system. And medication like trihexyphenidyl, we call it anticholinergic for tremors. Some of you guys might be on those medication. Now, this one thing that, are these medication helping with the disease progression? And the answer is no. It's just for the symptoms. Tremor, stiffness, slowness, walking, talking in some cases. And not for non-motor issues. Sometimes, yes, especially the thought process, other things, but it's mostly for motor symptom. The holy grail for this disease still not discovered. Now, are these medications efficacious? And the answer is yes. Almost all these medications are efficacious. So see, chemical name, then generic name, and now we are coming to the trade name. And you guys might have heard about Sinemet. Sinemet is a nice name because sin mean without, MS mean MSs, so without MSs. Because levodopa is very toxic to the gut mucosa, and that's why people get nauseous, and we combine it with carbidopa so that more levodopa can go to brain and get converted to dopamine. Then there are different kind of formulation, like you guys might have seen Sinemet 25-100, immediate release, extended release. Then there are inhaled form of levodopa for those jump start kind of thing, that if you are off, you want to get in the on period fast. Inhaled levodopa is one of them. Then Parcopa, if you have heard about it, it's the same levodopa, but it's an orally dissolved tablet. So if somebody has swallowing issues, we give this Parcopa. Then people have combined those immediate release and extended release in one capsule that's called Rytari. And then a new kid on the block is Crexont. There's a new medication, still the same levodopa, but it's an extended release with a beat kind of form. And then levodopa, of course, when everything slows down, same is true with the gut motility, and it can stay there, this tablet can stay there forever, sometimes for 4 to 6 hours, and you guys cannot get into the on period. And that's why people were searching for other routes. So duopa pump through a PEG tube, a lot of you guys, maybe anyone who has duopa pump? And the reason is because it's a surgical procedure, a PEG tube that we were giving you guys this levodopa. But now, scientists and people are getting smarter and smarter, and instead of putting a hole through in your tummy, we are giving you through the subcutaneous route. And it's like an insulin pump, and Dr. Malik would be discussing more and more about that. And the reason is because it just is combined with another chemical also, fast carbidopa, fast levodopa, so it is absorbed through the subcutaneous tissue and go through the brain. There is still no injectables because levodopa can metabolize in the systemic circulation very fast. Now, the question about when should you start the medication? There have been numerous studies on starting the medication. I came across only one study that it was in favor of not starting the medication. And there are reasons, because if you have symptoms and those symptoms are bothersome, affecting your life, why not to try medication? But then the question come across, is this levodopa or Parkinson disease medication accelerate my Parkinson disease? And the answer is no. Because this is a myth that you will develop those off-on periods. It's not the medication, just the medication is the duration of the disease. And there's the study that I'm projecting here, that in this third world country, they tried levodopa on a Parkinson disease medication naive patient, 5 year or more than 5 year into their disease. And when they started this medication, they developed more off-on and dyskinesia at that time. And that's why this concept of don't delay, start today. Again, if your symptoms are bothersome. If it is not, you can hang around there without medication. But if it is bothering you, why not to start something that can help you? Now, why levodopa? Because it has a long track record. It's very effective. It has sustained benefit, and it's very well tolerated. If we work together, I think we can make it better and better every visit. In 90s, this dopaphobia also come across that, oh my God, levodopa is causing more problem, accelerating the disease process. And then there was this one study, L-dopa, and it proved this myth wrong. So it's not causing problem with your disease in the sense that it's accelerating, but it's not neuroprotective also, meaning it's just for symptom control. Now, this slide, when you look at it, there are those off-on period initially, a series up and down, peak and valleys. And initially, if you see that it's not that frequent, but as the disease progresses, you need more medication and of course more frequent. The initial phase, we call it honeymoon period, but there's also a wrong term. It's a honeymoon period for us, not for you guys, because there is nothing like honeymoon in that. And just like any typical honeymoon, it won't last forever. So it's for a couple of years usually. And then we have to adjust your medication, giving you more of levodopa and more frequently. Now, discussing this dyskinesia, that there have been a large-scale study that actually people want to be in the dyskinetic phase more than in the off period, because in the off period they cannot function. But if dyskinesia become bothersome, like painful or causing problem, impairing your gait or other stuff or sleep, then we can do something. But if you guys are a little bit in the dyskinetic phase, that's okay, as long as it's not causing any problem. Now, this concept about dopamine dysregulation syndrome. So dopamine just don't work on the motor circuits, but on other circuit also, whether limbic circuit or other circuit. And that's why when some people, they are getting in the off period, they develop this drenching sweat, they go to restroom frequently, and it's just like that they want more and more, and they want more and more because it's the non-motor offs. So watch out for those symptoms, and then discuss it with your clinician. Now, when we talk about the timing of the medication, different people have different doses. It's not like those cardiology medication, blood pressure medication. It's not one size fit all. It's based on your symptoms, and that's why when you come to clinic, always bring your medication, not the list of medication, but the bottles. And you need to know what the medication is doing, is it helping, what symptom, and when are you wearing off, so we can help you with medication adjustment. And if you guys still can't do that, bring your wife, because she might know more about you than you yourself. Now, what I've seen, so I'll tell you about this dopamine. Some people call dopamine, which is a nice word, and that's why I projected that. And some patient call carbidopa, levodopa, especially levodopa, love your dopa. I love it. Because the way you guys massacre this carbidopa, levodopa is very cute. But call it love your dopa. So what I've seen when I go on inpatient service or people who are in nursing home, sometimes they come across some other issues, and some providers stop the medication completely. Please do not stop this medication all of a sudden. You will get very sick. I'm just coming from inpatient service and I saw one patient that medication was stopped. Or just imagine you are taking medication 5 or 6 times a day. You go to hospital, their schedule is twice a day or 3 times a day, and they reduce your medication and you got more sick. And that's why 3 out of 4 people with Parkinson's disease get sick in hospital. You guys go there for one reason, come out with another problem. So always, you need to have your medication with you, and you need to advocate for that also. Because a lot of us, we don't know what this medication is, what are the schedules, what are the timing. So see, some of my patients, if they don't get their medication, literally 30 minutes, they are miserable, right? And that's why that's really important. The one thing that I just heard from one of my patients is that nursing home has 1 hour flexibility, so I can give you the medication 1 hour later. What's the deal? But no, that patient was getting off 30 minutes before, so 1.5 hours she would be in the off period, which is a big deal, right? So that's why you need to have your list, and medication schedule needs to be written there so that you guys can advocate for that. So that was all about levodopa or love your dopas. Then another class of medication is dopamine agonists. So when in 90s this dopaphobia was going on, that was the time that this medication was getting more and more a hype. And then later on we learned that it can cause more problem than that, like cognitive issues and blood pressure drop and sleeping on the wheel and what we call impulse control disorders. Excessive shopping, binge eating, hypersexuality. So those medications like pramipexole, Mirapex, ropinirole, Requip, or the Nupro page, rotigotine page. So if you are on those medications, well and good, but watch out for those side effects also and discuss it with your clinician. It's in a pump form also that Dr. Malik would go over there, that Apocrine pump. More than 80% of my patients, they are on levodopa. I still use these medications, so please, do not stop this class of medication. Don't go home and say that, okay, I'm throwing this medication in the garbage. These are still good medication, but if you are having some side effect, please discuss it with your doctor. Then this other class of medication, we call it MAOB inhibitor, like medication like Resergiline, Azilect, Selegiline. Done?
Yeah, we will check on the we can go back to answer.
Sure. Okay, I'll wrap it up. If this class of medication, you are on it, you go to hospital, you need to stop it 1 week before. So see, for levodopa, I did not say that, but for this, because some of the doctors there would be using some of those medication like opioids or other medication, and that's why you can get more sick. So if you are on Azilec, stop it 1 week before going to the hospital, and you can stop it cold turkey. Then amantadine is another class, trihexyphenidyl, metoclopramide and antipsychotic. These are the no-go. Metoclopramide we use for GI motility. Metoclopramide, also called Reglan, it blocks dopamine receptors, same is true with those antipsychotic. DBS, I'm glad Dr. Kandu went over there. Botulinum toxin injection, if you have problem with your eyes, we call it blepharospasm. You are closing your eyes to the extent that you can't see or can't drive. That is a condition we see very commonly in patients with Parkinson disease. That is what we call blepharospasm, and we can help you with injection. Same is true with your jaw mobility. Same is true with your arms and legs. Those are what we call dystonia, or neck especially. Very, very common thing. The posturing and pain and spasm and all those things. Again, no neuroprotective strategy, repurposed medication. These are the medication that we use. It's already FDA approved. But now people have figured out that it has a role in Parkinson's disease. Medication like amantadine, it was approved for a flu, and now it's a Parkinson's disease medication. So this list of medication, especially the new thing that is coming in Roxel and some of those diabetic medication. Again, if you have that condition like diabetes, you can discuss with the provider, but do not start these medication because it's still going through a lot of research. Cannabis, all of you guys might know more than me. What affect quality of life more in Parkinson's disease, motor or non-motor? You can shout it. Motor symptoms or non-motor symptoms? Non-motor symptoms, because we suck at managing those. Trust me, I can see the things that is visible, like tremor, stiffness, slowness, walking, talking issues, but always discuss those non-motor issues with your doctors. It's a village. It's a multi-discipline strategy to manage a patient with Parkinson's disease. You guys can. This is the last slide because this is so cool. Download this app. It's for free, and it is helping with speech. Like, it will give you the feedback that what should be the volume of speech, the tone, every aspect. And it will give you feedback also, and it is for free. Now, the question about can we create a world without Parkinson's disease, and the answer is yes. Thank you so much.
Right there, say good luck. So that's a really